Let's move to the second presentation, and the second presentation is about pediatrics, and our colleague from the Gemelli University Hospital in Rome, Danilo Buonsenso, is going to talk about pediatric ME, CFS, and long COVID, clinical care models, and diagnostic gaps for younger populations. Danilo is a pediatrician at Gemelli University Hospital in Rome and member of the research committee of Global Health Research Institute of Catholic University of Rome. He has a PhD in public health and molecular sciences. Danilo, please.
Hello, you hear me, please?
Yes.
Okay, and you see my slides as well, right?
Yeah.
Okay, perfect. So first of all, thank you very much to all the organization for inviting me. I'm very sorry I could not join in person. I loved being in Porto, and I'm also a passionate of surfing, so it would have been a perfect destination for me. But I've had a very last minute issue, and I'm really sorry. And I also wanted to congratulate the organizing committee, because I'm seriously, I'm not aware of any conference on this topic with such a multidisciplinary coverage. So I'm really proud to be part of this meeting. So I will talk about pediatric long COVID and ME CFS in general, though most of the data you will see are referred to long COVID. I want to, and I know there may be some differences in long COVID and ME CFS, but my personal feeling is that these conditions go under the same umbrella of post-viral conditions, and they deserve the same equity in access to care and research. So this is why I usually do the same things to both patients until we have more data and more evidence to highlight us to how to treat ME/CFS or long COVID differently. So far, I consider them from a real-world clinical practice, the same condition in terms of diagnostic and care models. These are my conflict of interest. I've received funds on long COVID to study long COVID by Pfizer and Roche, but none other influences. I've written a book of long COVID. And my other declaration is that I know very well that we need trials and better evidence to improve the care of ME/CFS and long COVID, particularly in children and adolescents. I know very well that we need funds. I'm trying very much to apply to funds to study more these conditions. But unfortunately, referees sometimes reject us because they themselves don't know anything about this condition and reject our applications due to no reasonable reasons. And the other point I want to declare before my presentation is that, as also the presenter mentioned before me, long COVID sometimes, although we don't have a very clear evidence about how to manage them, we need to be aware, and this is my straight position, that long COVID can be a very severe organic condition, like any other condition, cancer. Some patients, even young people, die due to this condition, or sometimes people take their own lives due to this condition, to highlight how much severe in this condition. And this is why, although I'm aware we need trials and more evidence, but sometimes in medicine it's very much accepted to have off-label indications for very severe conditions where we don't have other options. This is agreed for severe infections with multi-drug conditions, cancer, but still people question this may be reasonable for long COVID and ME/CFS. So when when it happened to me to have these severe cases, I asked myself, should I just say wait and see what happens, or okay, this is a very severe case and maybe we can do something. And this comes from this. This is a very long debate, because many times even my colleagues tell me, first do not harm. But first do not harm is a very mainstay of our practice, and of course I do respect what Hippocrates said thousands of years ago. First do not harm. But sometimes even doing nothing, in my personal opinion, is harming, particularly when now we know some conditions like since 50 years, like ME/CFS and long COVID. And my personal feeling is that when we have the most severe spectrums of these conditions, we do have to do something, because nowadays we know a lot about the pathophysiology of long COVID and ME/CFS, as we will see during the program. And the other point is that in pediatrics, most of the things we do are off-label, because most antibiotics are introduced after trials in adults and then translated in pediatrics without specifically the pediatric or neonatal trials, or even preterm newborns. We don't have trials for preterm newborns, and we use the off-label. So this is why I do, in some selected cases, something for these children. The other point I want to highlight is that nowadays we are at the end of 2025. So I'm not talking anymore about what is long COVID in children, the epidemiology, because this was the very first publication on long COVID we did in 2021. We are not in the scenario that long COVID is a preliminary evidence. We have millions of patients all over the world. Long COVID has been literally described everywhere in the world, including Latin America and Africa. We are now at the level of knowledge that we know that even in children, like in this study we published some months ago, but this was also replicated by other centers, there is a clear chronic inflammatory signature in patients with long COVID, even in children and adults. There is endothelial cells activations. So the microcross theory has been widely replicated in every country. So long COVID is an organic disease, and we know a lot nowadays. It's not preliminary anymore. We know that long COVID and ME/CFS may have different subtypes of clinical presentation. Some patients may have all of these cardiorespiratory, musculoskeletal, abdominal, and neuropsychiatric symptoms. Some may have a predominance of some symptoms, like some may mostly have a cardiorespiratory cluster, a fatigue cluster. Some may have a neuropsychiatric cluster. So we know a lot nowadays. So we have to move from the period where we needed more evidence. Of course, we need more evidence, but we need to translate our efforts on pharmacological studies and biomarker studies. And in the meantime, as we know, long COVID since 5 years and ME/CFS since 50 years, we really need to implement daily care, daily clinics that offer simultaneously clinical care and research, because we need to know more. So every single patient must be offered real life practice, but also research opportunities, because it is true that we don't know yet very well what is the ideal model of caring for these patients, and I'm proposing our model here. But whatever model you decide, the very most important step that should be done in every single country in the world, and hopefully recognized formally by a government, is to recognize that long COVID and ME/CFS are real organic problem, and these patients need to be offered any sort of care. This is the very first step. So do whatever you want. You can also just follow up patients, but offer a formal care where patients do feel to be accepted. And secondly, once you establish a pivot center within your countries or your region, of course, try to establish a network with family pediatricians and family physicians from the outpatient settings, in order that at least patients can receive a clinical diagnosis and be referred to a referral centers, at least for a clinical follow-up. And ideally, as we are knowing much more, we are interconnecting a lot with international experts as today, we need to develop local guidelines. Again, there is not one guideline who is better than another, but try to do your best based on your local resources and on the literature. And this is basically a very diagnostic summary, a number of basic tests we do here in our center, and I will discuss a bit more in details. And this is not a rigid protocol, so this is a number of investigations that we do based on main clusters of patients. Like, for example, I will focus a lot on this central pathway because most patients suffer from fatigue and postural orthostatic tachycardia syndrome. So once a patient have a diagnostic criteria of long COVID or ME/CFS, we move to a diagnostic pathway because this diagnostic pathway, although may not have a clear therapeutic response, but it's important to have a recognition and sometimes even to provide certificates in order that patients can have social support in terms of money from the political backgrounds, because patients may need to stop working or to work less or to go to school less, because this is part of pacing. And as a reminder, the fatigue of patients is clearly due to muscular abnormalities which worsen after exercise, because these patients suffer from post-exertional malaise. So this is not just fatigue due to lack of movement, because these patients like stay in bed most of the time. The muscles of these patients have organic differences compared to the muscle of patients that simply do not do practice. And indeed, where we do the cardiopulmonary exercise testing in our patients compared to healthy controls, as you can see, several differences were statistically significant. And we already some years ago documented that patients with long COVID, when ME/CFS, when do a cardiopulmonary exercise testing, do have objective muscular and cardiorespiratory abnormalities compared to healthy controls. And like seen in these patients, the cardiopulmonary exercise testing, unless we know that patients suffer from a very severe form of post-exertional malaise, but at least at base can offer a baseline and sometimes also monitoring over time. Like this patient that, as you can see, in 2 years was able to move from a very basic protocol to a more complex protocol here, as you can see from the 7 to 12 protocol, like the ability of doing the fourth move from submaximal to maximal, and like signs of pulmonary hypertension move to from unlikely to likely. So you can also monitor improvements over time using the cardiopulmonary exercise testing. But one of the cornerstones of these patients is that more than 50% of these patients suffer from postural orthostatic tachycardia syndrome. And despite this is documented since decades, most clinicians still think that when patients feel tachycardia, palpitations, or fainting, they think this is due to psychological or psychiatric issues. But it is very simple to document the POTS in children and adolescents as well as in adults. And you can either use a very simple 10 minutes 10 test or a 24-hour electrocardiogram with heart rate variability. The heart rate variability is a number of parameters that we have documented even in children do differ when you compare the patients with healthy controls, and this heart rate variability can discriminate between the sympathetic and parasympathetic imbalance compared to healthy controls. So basically for us, a 24-hour electrocardiogram, a 10 minutes 10 test, and a cardiopulmonary exercise testing, if patients can afford to do that, is like the first line physical approach. As you can see, this patient who was sent to the psychiatrist, as you can see, only standing up or only going to the toilet, his heart rate moved from 70 or 80 to 140, 150, only walking a few steps. Or as you can see in this case, this is another girl, again sent to the psychiatrist at 14 years of age, despite she was very fine in terms of mood. And only when she woke up in the morning, or here was being in a school, only going to the toilet at school, her heart rate, the baseline was very high, 100, and only going to the toilet, this moved her heart rate to 175 to peaks of 200. And her POTS usually respond very well to ibabradine, even in adolescents. And as you can see in this case, the mean heart rate moved from 100 to 75, and peaks moved from 200 to a maximum of 150. And this was along with the clinical improvement. Now, so this, we know that ibabradine can provide improve the balance between sympathetic and parasympathetic system, and therefore controlling the heart rate of these patients. And although we are aware that not all patients respond to the first line treatment, and this is why we need a personalized and step-by-step approach. We are doing some studies to predict who will respond or not to ibabradine based on our heart rate variability parameters, but this is still research practice, so I will not go in details. But this is everything to say and explain why, in a step-by-step approach we do in our diagnostic and care model, we start with a 24 hours electrogram, then the 10 minutes and test, and if the patient does not suffer from severe post-exercise malaise, with the cardiopulmonary exercise testing. And first of all, if we document POTS, the first we do, we try to regulate POTS with ibabradine. But as I said, we may need another step, because patients, for example, may suffer from insomnia, chronic headaches, pain all over the body, and this is why we do to every patient electroencephalogram, the electromyographies, but also the pseudoscan if you cannot do the small fiber biopsy to document the small fiber neuropathy. These neuropathies are very well documented in long COVID and BCFS, and not every time, but most of the time, have a good response to gabapentin, which is historically an anti-seizure medication, but it has very good effects in pain control, and last but not least, also has a stabilizing effect on mood. And this is important because some patients can also have a mood severely affect, either due to an organic involvement of the disease in the brain, but also due to a response to a drastic change in life. And this is why, as a step 2, we may need to add gabapentin or melatonin to improve sleep. And this is important because at this level, we are mostly at the symptomatic approach. These medications are usually well tolerated. We have a lot of experience due to similar conditions. And so this is, in my opinion, like the basic approach, the less severe in terms of costs and side effects. However, patients may still not improve. And we know this is widespread, documented all over the world, that particularly young adults and older adults who suffer from thromboinflammation following COVID. In long COVID, it is widely demonstrated. Particularly at the beginning of the pandemic, we were doing the lung perfusion CT scans, and we documented that some patients had impairment in the lung microcirculation, very much described in adults as well. And this is an important paper published on Science, so we are referring to the top of the science available in medicine, and complement this regulation with thromboinflammation are clearly demonstrated in long COVID. This means that endothelial cells are hyperactivated. The endothelial cells are immune cells eventually, so they activate the immune system, the chronic inflammation, and the chronic inflammation can activate microclots, which can impair the peripheral circulation. And this is why some of us in severe cases do consider low-dose anticoagulation. And in this regard, I usually prefer to use low-dose enoxaparin or rivaroxaban because at a prophylactic dose, because we don't have macroscopic embolism in these patients. And one of the reasons I use heparin or rivaroxaban is that because these medications have clear effects as antioxidant and anti-inflammatory effects on endothelial cells, and we know that there is thromboinflammations in these patients. So if patients don't improve on the first two steps, I move to the third steps and consider low-dose anticoagulation at prophylactic doses. They usually are very safe. Again, this may not be enough, and some patients really remain bed-bounded for 20 or more days. They are not able to attend school anymore, no sports, goes out with friends, basically have no life, and some of them have severe brain fog. Really, some of these patients prefer to die rather than living with BCFS or long COVID. And now we have a lot of studies, and these are three of the most important studies in the history of long COVID, despite a brief history. But these three independent studies documented that if you take the blood of patients with long COVID and put it in mice develop the same symptoms of adults with long COVID, meaning that there is some in the blood that can trigger all these symptoms. Most probably they can be immune cells or autoantibodies. And this is why we can empirically and off-label try to block this chronic inflammation in autoantibodies. The easiest, although most expensive tool to do that is using intravenous immunoglobulins, which are used since probably a century in idiopathic immune-mediated conditions. And this is why, as a fourth step, I do consider intravenous immunoglobulins or along with or without low-dose naltrexone or cannabis to reduce inflammation, and IgIB to reduce autoantibodies. But again, this may not be enough, and as also mentioned by Susan Levine before me, again, we have a lot of evidence now. This is again science translational medicine, so we are talking about the top of the science. Not a lot of conditions have the high level evidence as long COVID in the whole history of medicine. And long COVID has clearly an evidence of chronic immune activation with tissue T-cell activation in several organs and tissues like the brain and the gut. And nowadays we do have medications that can control the T-cell activation. And Susan just talked about low-dose rapamycin. Another option can be rituximab, which blocking the B cells block the production of autoantibodies, but also the activation of T cells. But rapamycin looks the cheapest option and the safest at low doses, because this is also used a lot as an anti-longevity medication. Low-dose rapamycin already said a lot, Susan, and this is part of my fifth step for those patients not responding anymore, waiting for new trials, and maybe one day we will move rapamycin to one of the first steps. Of course, all this approach goes along with mental health support, family support, pacing. Pacing remains the most important thing. Social support, meaning that children and adolescents may need to have personalized schedules at school, allowing absentees when they need to rest, allowing scheduling in advance of examinations and so on in order to make the school experience less heavy as possible. Once we start all these medications, we don't know how to step down. So this is really no evidence about that. Basically, if patients do better for 1 year or more, I very gradually try to reduce the doses of the medications, and once at a time eliminate the most heavy medications, usually if possible monitoring, having objective evidence of improvements with the 24-hour electrocardiogram and the cardiopulmonary exercise testing. So this is my very fast overview. Of course, I'm happy to share my slides if you want, if you need them. If you want to go a bit deeper to our protocol and what we do in our daily practice, I have a blog where you can access every Sunday information. And also I've written a book on that, which is mostly about the neglect that patients suffer. And I've written that not only to educate doctors, but also the family members, because many times family members are the first not trusting our patients. But the trust of these patients is the very first step in terms of care. And there is also a Portuguese version if you may think it useful. And thank you very much again for your invitation. I've finished here. I'm happy to respond to any answers if you have them, or feel free to email me if you want to discuss anything more. Thank you very much.
Thank you, Danilo, for your very interesting presentation. We have time for 1 or 2 questions now. I don't know if you are going to stay with us till the end of the session, or we must do all the questions now. Danilo.
Well, I remain online. So you have the Q&A at 12:30, right?
Yeah. Thank you.
So
but
we remain online when it's time of the Q&A.
Okay. So I have a first question for you. Do you know if the prevalence of long COVID in the children is similar to adults?
Yes. So it is. We don't have the perfect data about the prevalence, but what I do strongly believe, also based on data, is that it is less frequent compared to adults. It still is a massive amount of absolute numbers, but luckily it's in terms of prevalence much less compared to adults. Yeah.
And what is the age of most prevalence in children?
Yeah, it's mostly adolescents from 12 to 18 years of age, although very less commonly from 6 and onward. But the biggest problem is 12 to 18.
Okay, thank you. Any other question from? Yeah. No. Microphone, please. Microphone, por favor. Okay.
Grazie, thank you. I'm just wondering if even in children, they still find a difference in gender, in prevalence.
Yeah, I've heard it, yes. So some studies show that slightly higher prevalence in female, but not every studies. And so basically the gender difference is not as much pronounced as in adults.
Ok, thank you. Grazie, anch'io sono italiana, la saluto, la ringrazio.
Grazie a te.
Okay.
Okay, good morning. I'm Miguel Castelo Branco from the University of Coimbra. A very nice talk. I have a question about, you talked about the immunoglobulins that can produce symptoms in mice models. We know that there are some types of immunoglobulins that are reported in long COVID. It's very difficult for the average patient to do the titration of these immunoglobulins. Can you make a comment on the profiles of long COVID that you are aware of?
Yeah, so basically, it is very true what you said. We have many phenotypes, but as you said, the average patient and the average center, including myself, we are not able yet to have in clinical practice, in real life clinical practice, the possibility of discriminating those patients having specific autoantibodies or immunoglobulins that may trigger long COVID. So my personal approach is that when a patient is severe enough to think about moving at the third step, I do empirically try as off-label IGIV a few times every 1 to 2 months, 2-3 times, and then we see if patients tolerate without major side effects and he has clinical improvement, we go forward with IGIV. If patient has either side effects or no improvement at all, we stop the IGIV. Because as you said, those findings I showed in those 3 studies, mostly from New York, but one was from Europe, from USA and one from Europe, they are not available in clinical practice. So although we know that we have different subtypes, we don't know how to translate in real practice who will benefit from each treatment. So this is why I do a step-by-step approach, trying, everything from the simple to the most complex, because we don't know how to predict yet. Of course, I start only in the more severe patients, as I mentioned several times.
Yeah, I have a very brief comment on this, because we know that several of the antibodies that are elevated in severe acute COVID, like the endothelin receptor, so most of the anti-protein G autoantibodies, they are elevated, and there are at least some patients in long COVID that have some of these antibodies elevated. And this brings me to the first talk where somebody said no biomarkers. So until we find these biomarkers, if a patient has 3 autoantibodies and another has 5, the clinical phenotype will be entirely different. And we know that some of these autoantibodies are functioning because of the cardiomyocyte assays. So I think we are still lagging very much behind because we don't have biomarkers. And so I think this should be the next strategy for research in this area. I heard your epidemiological talk, but we don't really have a perfect reference for epidemiology. The criteria are still very variable. And I stop here. My comment was maybe too long.
It was very interesting, Miguel. Thank you for your approach.
No, I totally agree. So that is the priority. But as I said, we may need maybe 1, 2, or 5 years more to arrive to that evidence. And in the meantime, some patients are very severe. So that is why I do a step-by-step approach, because eventually we cannot do those tests we hope to have in some years to each patient. And so we do know from the literature that some 50% of patients can have those autoantibodies, and eventually to the most severe, we try to target them either with IVIG or to reducing inflammation with low-dose rapamycin. We try empirically, like we do in the same way with empirical antibiotics in pneumonia. We try to start with amoxicillin. If no response, ceftriaxone. If no response, I'm saying like meropenem. No, we do the same here, because some patients cannot wait anymore other 5 years, because some of them, even teenagers, otherwise they will not be here with us in 5 years anymore.
Any other question? One question? Okay. Antonio?
Danilo, Antonio here. I was wondering if you could consider including on your therapeutic approach the watch of outstanding and most beautiful movies like Amarcord. So I would, at least patients when look at this movie and think of their own disease, and this can be really, really important. So thank you for reminding us of this masterpiece from Mr. Fellini, which I really miss a lot, because the Italian films were just absolutely outstanding. So thank you very much.
Well, Danilo, we are still there. Okay. About rapamycin, we have already listened to Susan talking about rapamycin. Rapamycin is, I think, is an antibiotic. It was used formerly in transplanted patients, and I think I'm right. I'm not sure, but I think it was it has been a polemic some years ago about the mechanisms of aging in patients using rapamycin. Do you know something about it, about rapamycin and aging factors?
Yeah, so rapamycin has come back in in the global interest with the growing field of anti-aging, and actually there are quite a few studies, even on major journals like the Lancet, use testing the low-dose rapamycin for anti-aging. And we don't have data eventually demonstrating that those patients lived more, but those studies that documented that the inflammatory markers in the long term were lower in patients with using them compared to adult or ancient patients not using them. Obviously, of course, I don't suggest its use yet as an anti-aging medication, but its role on at low doses on the mTOR pathways, which we also have pediatric data showing that there is an mTOR hyperactivation, which eventually is involved in chronic activations of T cells and T cell exhaustion. So its activity on downregulating the mTOR is very well documented in clinical practice. It is also used in some pediatric immunomediated conditions. So, and nowadays we do have some observational studies in young adults showing improvement in fatigue, and I personally do also have some patients that have completely changed in positive their life with low-dose rapamycin. Of course, again, we need more data to use it routinely, but for the same reason I said in the beginning of my presentation, I do think that it's ethical after informing the patients in the most severe cases to try it as off-label.
And sorry. Okay, no, you can finish.
Yeah, because eventually this evidence about T cell activation, T cell infiltrations, and mTOR activation, chronic inflammation in long COVID in CFS is not a theory anymore. There is evidence. Of course, as the colleague was saying before, we will need the test to better characterize which patients do have this subtype and will benefit the most from rapamycin. But in the meantime, the most severe cases, either dying or surviving, I think it's ethical to try it.
And do you use it for a limited range of time or not?
Yeah, so really, so as I said, once we starting is difficult, but stopping is even more difficult because we do have some evidence, even case serious from starting, but it's always difficult how to stop. So I do a very much empirically. So if patients tolerate well the medication and they monitor every month the blood test, urine, the cholesterol, and they have no side effects, I usually leave a patient on a medication for at least a year if the patient is doing well. And then I really slowly reduce in years, because, patients are really worried to stop that, once they are better.
Thank you.
Fernando Pimentel from Nova Medical School. Thank you for your presentation. Coming back to IVIG, I would like to clarify which patients should benefit from this kind of approach.
So, as the previous colleague was saying, in an ideal scenario, we will have in a few years some studies showing a cluster of multiple autoantibodies in some patients and in others not. And those patients with the multiple autoantibodies are, in theory, those benefiting more because we know very well that IVIG blocks autoantibodies in several immune-mediated conditions. But we are not there anymore. So my approach is that one patient is sick for 2 or 3 years, most of the time bed-bound, severe on a Bell scale, has not improved with POTS medications, is not improved with maybe low-dose naltrexone, gabapentin, nicotine, or cannabis. So, and this still very severe in the Bell scale. I just empirically try and see, okay, if you are doing well, better we continue. If you're not if you have not benefited at all, from IVIG, we stop it.
Danilo, we have one more question before the break. So, Dr.
Thank you, Daniel. My name is Rowan Gardner from Precision Life. We've been working with Chris Ponting to analyze their decode ME population, and it's really just to say that our preliminary findings see very high prevalence of variants across not just mTOR, but various regulatory genes acting on that pathway. We'll have a preprint up in 2 weeks' time, and I think that will expand our understanding of the benefits of rapamycin in treating these patients. So a little bit of advertising, but I think rapamycin has a lot to offer.
Oh, okay, thank you. No, this is not advertising, because the preprints are also important for us to adapt, particularly if they confirm the studies or maybe they don't confirm what we know so far, and so we may be even more cautious. So yes, I'm sure I will be notified somehow when the preprint is out, and I will read the very first day. Thank you.